Hi, my name is Umar Devori, and I am a faculty member in the Division of Head and Neck Surgery at the University of Pittsburgh Medical Center. And it's my great pleasure to speak to you today about the management of oropharyngeal cancer and the role of de-escalation in the management of this disease. I'd like to start off by thanking the organizers for giving me the opportunity to present today. By way of disclosure, the work that I'm showing today has been supported in part by grant funding from the Department of Veterans Affairs, as well as support from the PNC Foundation and from these companies which are listed here as well. I am not disclosing or presenting any data which would be of direct relevance to any of these commercial funding sources. Here are my sources for this lecture, and I encourage everyone to have a look at some of these seminal publications at the end of the talk. The objectives for the talk are as follows. Firstly, we will discuss some of the epidemiology associated with Hpv associated oropharyngeal cancer. Secondly, we will understand the use of trans or robotic surgery for the patients who have Hpv associated oropharyngeal cancers. And finally, we will discuss the role of de-escalation of therapy for patients who suffer from Hpv associated cancers. And I'm going to focus a bit more on the de-escalation of the adjuvant therapy in the context of primary surgical management of these patients. And we'll also discuss a little bit about some of the newer trials addressing the use of definitive chemoradiation in the management of these patients. As we all know, head and neck cancer is a devastating disease. We postulate that there are about 50,000 new cases a year in the United States. The majority of these tumors are derived from the squamous mucosal epithelium of the head and neck. And as we all know, these tumors are often caused by exposure to tobacco and alcohol. Although head and neck cancer is relatively rare in North America and particularly the United States, it is a devastating disease which is a very common cause of cancer-related fatality in the world. And as such, there is great interest in studying the epidemiology of the disease and understanding some of the ways to treat this disease more effectively. Recent data has shown us that while we think of head and neck cancer, or what we used to think of head and neck cancer as one entity, it really is comprised of two distinct diseases. There are tumors that are caused by exposure to tobacco and alcohol, as is shown here in a typical patient of ours from Pittsburgh on the left-hand side of the screen, as she's celebrating her 100th birthday with a cigarette. These patients have tumors that are associated with carcinogen exposure, which results in a very specific genomic and phenotypic characterization. These tumors tend to be heavily mutated in p53, which then leads to a dysregulation of the DNA damage repair pathways and ultimately leads to carcinogenesis. These tumors also have very specific genomic alterations, such as 11q13, 3p, 4q, etc., which are shown in the cartoon. But specifically, these tumors often have a low expression of a particular protein known as p16, which is a tumor suppressor protein. On the other hand, Hpv associated tumors are driven by the expression of viral oncoproteins, specifically E6 and E7, which are encoded by the human papillomavirus. These proteins, E6 and E7, interact with retinoblastoma protein and p53, E6 with p53, and E7 with retinoblastoma protein, as shown in this cartoon. And this leads to dysregulation, once again, of damaged repair pathways and leads to oncogenesis. Interestingly, for HPV associated or HPV driven tumors, we find that there is an increased expression of the protein known as P16. Again, this is a tumor suppressor protein, and we think that this is really a compensatory mechanism that the tumor cells are using in an attempt to escape some of these DNA damage checkpoints. However, the exact molecular mechanism of this remains unknown and requires further investigation. And the molecular details of this are beyond the scope of our current talk today. Nonetheless, the changing face of head and neck cancer is one that is pretty obvious in all of our practices. Those of you who see patients with head and neck cancers know that many of these HPV-associated cancers occur in younger patients. Because these tumors are driven by the human papillomavirus as opposed to tobacco and alcohol, these patients often have infrequent tobacco and alcohol use, or often they're never smokers. And for some reason, this disease seems to have a predilection for occurring in middle-aged Caucasian males. And we don't quite understand why this seems to be the case, but there is definitely a preponderance of middle-aged Caucasian males in the HPV-associated tumor population. Here's some data that was published by Anil Chaturvedi about 10 years ago now, where he described some of these characteristics of this disease type. And we can see in this data that while oropharyngeal cancer overall had sort of seen a slight increase between the 1980s to the 2000s, the HPV positive oropharyngeal cancers were increasing at quite a dramatic rate. In fact, HPV associated or HPV positive oropharyngeal cancers increased by 225% over the course of this study, whereas HPV negative cancers actually showed a decline of about 50% over the course of this study, possibly due to a greater understanding of the toxic effects of tobacco and alcohol, and therefore a reduction of use of these drugs by our patients. Given recent trends, we have seen that HPV positive oropharyngeal cancer has surpassed cervical cancers and is in fact the #1 virally driven cancer in this country. Not only did we see this at a more national level, as shown by that data from Dr. Chaturvedi. Here's a graph looking at new cases of oropharyngeal cancer from our patients at UPMC. And we, once again, find that these oropharyngeal cancer cases are increasing at a dramatic rate, once again, occurring significantly in younger adults. As I had stated before, HPV-associated oropharyngeal cancer has overtaken cervical cancer in this country. And once again, this is some other data from Anil that shows similar characterization in these patients. Why is this so important, and why do we care so much about the HPV stratification or the HPV status in these patients? Well, here's some data from Ki and Ang, who presented this paper in the New England Journal of Medicine. This was a prospective analysis from tissues collected from a completed Rtog 0129 trial, which showed that the risk stratification for these patients was clearly dependent on HPV status. And so in this particular trial, there were 266 patients with oropharyngeal cancer with known smoking status as well as tumor HPV status. 178 patients had HPV positive tumors, whereas a remainder had HPV negative tumors. These patients were then further stratified into by smoking history into less than 10 pack years versus greater than 10 pack year smoking history, and then of course stratified by the T and N stage. And what was very interesting from this data is that the patients who had a low risk disease, that has had a very low smoking history and had relatively small T stage, had significantly improved survival when compared to patients that were intermediate risk or those that were at high risk. So 93% PFS, progression-free survival, versus 70% in those with intermediate risk, and 46% in those patients that had HPV negative tumors. So this therefore shows us that the risk stratification really does fall out based on the HPV status of these patients. And this is the same data demonstrated in graphical format, showing that HPV positive patients have much better survival when compared to HPV negative patients. In fact, this survival was best shown or best depicted based on the P16 status. So therefore, P16 is the most reflective marker of survival and progression-free survival in patients with oropharyngeal cancer. Here's some data from Carol Fakhri, who's at Johns Hopkins, who has shown that over the past 20, 30 years, patients, because they're having a younger age of diagnosis, there's actually a 18-fold increase in the frequency of 5-year survivors of oropharyngeal cancer. What this means is that we're going to have more and more patients who are surviving treatments of this disease, and this has allowed us now to really start thinking not just about the oncologic benefits of treating these patients, but really think about the quality of life for these patients. In other words, what is the long-term quality of life for these patients who are going to be surviving treatment for this disease? So HPV associated cancers at this point in time, we know have an excellent prognosis from an oncologic standpoint. I just said it was 93% for the low risk patients, 70% for those with intermediate risk, which is still far better than the 40-ish% for the HPV negative patients. But as we treat these patients, and in that particular trial, Rtog 0129, it was really, these were patients that were treated with definitive chemotherapy, radiation therapy. They were not typically treated with surgical treatment management. So there are definitely functional consequences to the treatments of these patients. And so the big questions that exist in the field is, can we maintain oncologic outcomes for these patients while improving or maintaining their function? And just by way of a side note, noticing that those patients that were enrolled in that Rtog trial would have typically been staged as a T3, T4, but with 93% survival, didn't really jive in the field. We were struggling as an oncologic community to understand why patients would present with relatively advanced disease. In other words, in the AJCC 7th edition, tumor that was staged as T1N1 would be considered a stage 3. And this stage 3 patient was the same as a T3N0, for example, as a stage 3 patient based on the 7th edition AJCC. However, in the context of HPV positive disease, these patients would enjoy a 93% survival. So this was incongruent with the fact that they were being staged as a stage 3. So this led for the adoption of a new staging system, and this AJCC 8th edition has been now rolled out, and we continue to use this on a not infrequent basis. And so with this new HPV positive disease, we are now seeing that a significant percentage of patients are downstaged using the 8th edition. And in fact, 94% of patients are downstaged in the 8th edition. So a patient who would have been a stage 1 in the old 7th edition, it was only about 3.2% of patients. Now a full 63% of patients are going to be staged as a stage 1. This is some excellent data from John Kramer, one of our former fellows from the University of Pittsburgh, who's now in Detroit and is doing extremely well. And John published a very important paper. What's also true is that if we treat these patients in using the 7th edition or using definitive chemoradiation therapy, as shown in these various trials, and this is a paper published by Mitch McTay, who looked at the toxicity associated with definitive chemoradiation for patients treated on these protocols, these Rtog protocols, 43% of patients will have severe late toxicity, which suggests that the dilemma for these HPV positive oropharyngeal cancer arises when we have patients who have a very low risk of relapse and a very high rate of potential cure, who suffer from substantial amounts of late toxicity. And so this again begs the question, can we de-intensify therapy for those patients who are likely to have a good outcome and therefore prevent them from having the significant late toxicities, which could involve gastrostomy tubes and difficulty swallowing. But before we get to this point, I kind of wanted to take a bit of a historical journey to understand why we are where we are right now. For those of you who remember the classic approaches to these oropharyngeal tumors, as I did in my training, the open surgical approach was a fairly morbid procedure for these patients, often requiring a mandibulotomy, a tracheostomy, a microvascular reconstruction, and a gastrostomy tube placement for these patients. And here's a picture of a midline approach, labiomandibulotomy approach for access to a tumor at the tonsillar fossa, depicted by this black arrow. And so these large open surgical procedures required significant morbidity and induce significant morbidity for the patients. Despite this, despite the need for tracheostomies, gastrostomies, ICU tubes, ICU stays, prolonged convalescence, many of these patients needed chemoradiotherapy anyway in an adjuvant setting. And so this led the field to consider the concept, of using non-surgical therapy in a definitive sense and avoiding surgery for these patients. One of these important trials was published by Calais, where stage 3 and stage 4, 7th edition, of course, oropharyngeal cancer patients were treated. There were 222 patients. They were randomized to receiving RT plus minus 5-FU and carboplatin, so 70 gray over 7 weeks, plus or minus chemotherapy. And he showed that the addition of platinum to these patients improved survival significantly. Overall survival went from 30 to 50% roughly at 3 years. Now, once again, notice that these numbers are much lower than the 90% rate that I quoted for progression-free survival from the Rtog Kianang paper, suggesting that this cohort of patients probably had a significant percentage of HPV negative disease, although at the time of this particular study, HPV testing was not routinely used in these patients. Calais also described that local control rates were significantly improved in the CRT group, and this trial really established chemoradiotherapy as the standard of care for patients with advanced stage disease. However, these treatments do come with a significant toxicity. As I said, this is the paper from Mitch McTay showing that 43% of patients suffer from severe late toxicities, which includes 3+ toxicity. This includes concepts such as feeding tube dependence for more than 2 years after radiation therapy, pharyngeal dysfunction or laryngeal dysfunction leading to dysphagia. And of course, the dysphagia in of itself, while not being while we can manage that, may not be as concerning. The reality is patients who have this dysphagia will progress to have aspiration in many cases, and this aspiration, when uncontrolled, leads to cancer unrelated death. In other words, they're cured of cancer, but they succumb to pneumonia basically, and they die because of this pneumonia. So this led us to think about ways to change these chemoradiotherapy paradigms to try to improve the oncologic function for these people while maintaining their survival. So here's a trial that was published by Shanti Moore and Tony Smalak. This was Ecog Trial 1308, and the concept of this trial was to give patients induction chemotherapy followed by low-dose or standard-dose RT in the context of Hpv associated resectable squamous cell carcinoma of the oropharynx. So here we see that patients that had oropharyngeal cancer that was resectable, they were tested with the HPV in situ hybridization or P16 IHC. These are all patients that were stage 3 or stage 4 based on the older staging schema. They were treated with 3 cycles of induction chemotherapy with platinum Taxol-based agent, paclitaxel, as well as cetuximab, and then the patients were evaluated for response. If they had a complete response, they were consolidated with low-dose IMRT with cetuximab given weekly. But if they had a partial response, then they were treated with full dose of IMRT to 70 gray with cetuximab weekly. And the reality is that for these patients, while there was a significant response rate to this induction therapy, the 2-year progression-free survival was about 80%. And when we looked at the subset analysis in this paper, it was essentially a negative study. It was essentially a negative study where the 2 groups really didn't show a significant difference. And so the concept of giving this induction therapy followed by different doses of radiation for patients based on their response did not really work out to be a very meaningful step forward in the field. So this then begot the question, well, what else can we do in order to de-escalate these patients? And one of the great opportunities to best stage these patients is with surgery. And so we know that surgical management of head and neck cancer patients, especially the HPV negative case, allows us to get better information in pathologic staging. It allows us to know the pathologic nodal stage, allows us to assess for extranodal extension, allows us to assess for margin status, etc. And so the concept then came to the front that maybe surgery could be used to de-escalate these patients. And so while the open surgical approach was clearly very morbid, this was around the time that transoral approaches began to gain traction and gain greater acceptance in the space, especially the use of transoral robotic surgery, which was pioneered by Bert O'Malley and Greg Weinstein at the University of Pennsylvania. And so TORS allowed for much more directed access to the oropharyngeal region, and with the use of a selective neck dissection to allow for nodal management, we really had an opportunity here to surgically manage these patients and potentially stage them better and maybe de-intensify them. And so this led to the concept, I should say, of de-intensifying the adjuvant treatment for these patients. So maybe not the definitive setting, but in the adjuvant setting. So robotic surgery can still help patients to personalize therapy because we may be able to avoid radiation in some patients, but many patients still receive adjuvant therapy of some form, either RT or CRT, RT alone or RT plus chemotherapy. And the trials to demonstrate the outcomes and the use of reduced radiation or avoiding chemotherapy, etc., are really needed. I'm going to talk about some of those trials that are coming forward. And we need level 1 evidence using transoral robotic surgery to make these decisions. And that's why cooperative group trials are so important. And I'm going to discuss some of these cooperative group trials in the next few minutes. But before we get there, I really wanted to talk a little bit about the rationale for why we decided to use transoral robotic surgery in these patients. So here's some really, really provocative data that was published by Lisa Lecitra from the National Tumor Institute in Milan. She published this in JCO in 2006, and she looked at a cohort of patients, all of whom had oropharyngeal cancer, that were treated with primary surgery. And retrospectively, she assessed these patients for their HPV status and then broke them down by those that were HPV positive or negative and those that needed adjuvant radiation therapy versus those that did not. And if you look at this relatively small but small number of patients, but really compelling data, that if you look at these patients that were HPV positive and did not need radiation therapy because they had no poor features on pathology, those patients enjoyed 100% survival over 8 years. 100%. So that's really spectacular data. Whereas those patients that were HPV negative and needed radiotherapy in an adjuvant setting, meaning they had probably more advanced disease, had, as expected, a 40% or so survival of 5 years. So these data really demonstrated the power of using, number one, HPV to stratify these patients, and number two, using surgery to potentially rationally deploy adjuvant therapy for these patients. And as a consequence of this, in the NCCN guidelines, there is the potential to offer these patients transoral or open resection of the primary, with or without neck dissections, and then based on this pathology, based on whether there are adverse features such as extracapsular extension, positive margins, etc., or no adverse features, the patients can have less therapy. But the goal, however, for these patients is to use the smallest number of modalities to treat the patients. In other words, we try to avoid giving these patients surgery and then chemoradiotherapy in the adjuvant setting. So this really, allows us to now think about how to rationally deploy the tools that we have, which includes robotics and other techniques, to try to refine our way of performing surgery and how we can then best treat these patients. And so this is where transoral robotic surgery comes into the field, and I'm sure many of you have seen this and have probably used this in your practice, so I'm not going to belabor the point, but basically by giving access to the oropharynx using these sophisticated retractors, we can bring a robotic system into the oropharyngeal region through a transoral approach, and then use the robotic system to then resect these tumors, ideally to negative margin. So at Pittsburgh, we asked the question, what is the role of surgery alone? We're basically trying to recapitulate that data from Lisa Lecitra to understand what is the role of surgery alone in these patients. And so we undertook a retrospective review and identified patients who were treated only with robotic surgery and looked at quality of life as their endpoint. Not survival as Dr. Lecitra did, but rather quality of life. And so we identified a significant percentage of patients. Of course, the vast majority are male, as you can see here. 74% of these patients were male. And we broke them down by staging. The vast majority of these patients were T1, T2, and 0 to N1 based on their AJCC 7th edition staging. And then we gave these patients quality of life surveys starting at 1 month after surgery to look at their recovery of their quality of life after transoral robotic surgery. And interestingly, what we found is that if you don't give these patients adjuvant therapy and they are treated only with surgery, their quality of life recovers pretty quickly after the surgery, and they do really, really well. If we now ask the question, what is the effect of transoral surgery followed by adjuvant therapy on these patients, then we actually have some very provocative data. And this was a paper that was published by Diane Ling when she was a medical student with me at the University of Pittsburgh, and now she's a radiation oncologist. Just graduated from residency. So what Diane did was she identified these patients who had oropharyngeal cancer, managed with primary transoral robotic surgery, and were either treated with TORS alone, or TORS with adjuvant therapy alone, or TORS with adjuvant therapy plus chemotherapy, so adjuvant chemoradiotherapy. And we looked at their quality of life measurements at different time points, 1 month, 6 months, 12 months, and 24 months. And in fact, it was very surprising that what we found was that using primary TORS, and you can see that here in graph A. So primary TORS means surgery up front, and they could have had adjuvant therapy afterwards. Their quality of life scores were actually better than those treated with definitive chemoradiotherapy. Of course, if you further break this down to people treated with TORS alone versus TORS plus adjuvant therapy, yes, if you have surgery alone, your quality of life is clearly better because you don't have the long-term xerostomia that's associated with adjuvant radiotherapy. And the same holds true for taste-related quality of life as well as saliva-related quality of life in these patients. And while we published this data in Oral Oncology quite a few years ago, there's been some very, very elegant studies from MD Anderson, from the group at MD Anderson led by Kate Hutchison, that's recapitulated these data. And we now seem to agree in the field that although surgery alone is preferred, even surgery with adjuvant therapy still seems to have a better outcome when compared to definitive chemoradiotherapy. And this is quite controversial in the field, but there are several papers that seem to suggest this. Once again, there's some advantages now to upfront surgery in terms of better defining the pathologic staging of these patients, and therefore this potentially informs our therapeutic decision making. And here's a very interesting piece of data from the Sinai group showing that clinical versus pathologic stage was significantly different, and that the percentage of people who got treatment altered as a result of surgery was quite a few, mostly based on their T staging and to some extent their nodal staging. But again, we have to remember that we are de-escalating. We're trying to de-escalate treatment for these patients because a vast number of these patients will do very well, and we probably need to downstage them based on the 8th edition. So John Kramer, when he was at Pittsburgh, asked a very important question, which is, if we look at people with early stage, 8th edition, stage 1, HPV positive cancer, and after they've had their treatment, we follow them for overall survival, then can you avoid adjuvant therapy in the new T1N1 HPV associated tumors, or the low risk HPV associated tumors? And the corollary question to be asked on this is adjuvant therapy really required for these patients? Now, does it really help them by having adjuvant therapy? So what John did was he went to the National Cancer Database and looked at all patients in a retrospective fashion who would be staged as stage 1 based on the 8th edition AJCC, and then identified a study cohort of roughly 2,400 patients. We then parsed this into 2 groups, either low risk, that is patients who had negative margin surgery, had just 0 or 1 metastatic lymph nodes with no adverse features, or those patients that had intermediate risk, that is, they had negative margins but had maybe up to 4 lymph nodes, which would have upstaged them in the on the pathology, or had microscopic external extension. And then we just looked at how these people were treated: surgery alone, RT, surgery plus RT, or surgery plus chemo RT in the adjuvant setting. And you can see the numbers of patients listed here, and this data is now in print. But this was an oral presentation at ASCO in 2018, and so I'm sharing the slides from that particular presentation, but you can find the published data. Very interestingly, what John found was that if you looked at the 4-year overall survival for patients with low-risk disease who were treated with surgery alone, followed by RT or chemo RT based on various parameters that were at the discretion of the treating physicians, there was in fact no change in their 4-year overall survival. They all enjoyed an overall survival of about 93%, and same number that seemed to come out from that Rtog 0129 paper that I showed you from Kianang. So this seems to be the magic number in the oropharyngeal cancer population, is that about 93% of people are going to survive, probably irrespective of the kind of treatment that they have. But this was a very, very interesting finding, in my opinion. When we looked at the subgroup analysis and looking at microscopic extranodal extension, we found that once again there was really no difference in survival for patients treated with RT, surgery alone, or RT or chemo-RT. But what's really interesting is that there are 60 patients in this particular group who had surgery alone and did not have radiotherapy, and some of these were people who declined adjuvant therapy, but many were patients who were never offered adjuvant therapy for whatever reason. And so I think that this was a very interesting finding, but troubling at the same time, because it suggests that some physicians are actually treating people based on the AJCC staging potentially, or treating people in ways that would not typically fall within the NCCN guidelines. Luckily, there doesn't seem to be a significant impact on survival for these patients despite that alteration of treatment paradigms. So these data, while being provocative, clearly raise the idea that maybe we ought to be tailoring our therapy for these patients in a slightly different way. Maybe we should be thinking about how to use these anecdotal experiences and actually define these problems in a much more concrete fashion. And I love this cartoon, since it seems to suggest that the early acupuncture was all by happenstance and by serendipity, and in fact much of science does go that way. And so here in 2021, we now have a cohort, or I should say a cadre of trials that are being used to treat patients who have HPV associated cancer with this context of surgical de-intensification. So I don't mean to belabor these points too much, but I do want to go over these because I think these are really, really important concepts. And so if a patient has surgically resectable HPV associated disease, the patient undergoes transoral surgery to resect this, and this could be robotic or non-robotic. It really doesn't matter what the modality is, as long as negative margins are achieved in the resection. If the patient has low-risk disease, that is, has negative margins, only 0 to 1 lymph nodes being positive, these patients can go for observation, and this is being tested in the Ecog 3311 study, which has several arms. And this is the arm A of that study, which I will talk about in just a few minutes, as well as another trial called Best of, which is being run by Christian Simon in Switzerland, at Lausanne. After transoral surgery, if patients have an intermediate risk, that is, they have maybe 2 to 4 lymph nodes, maybe they have lymphovascular invasion or perineural invasion, or maybe they have close margins or microscopic extranodal extension, these patients could be treated with adjuvant radiotherapy alone, avoiding the need for chemotherapy. And this is being tested in Ecog 3311, as well as another trial called Pathos, which is being led by Terry Jones from Liverpool, and this is a predominantly European trial. And the real question is, can you reduce the dose of adjuvant radiotherapy from 60 gray to 50 gray? And finally, for those patients that have surgery, but then have high-risk disease, that is, they have positive margins, maybe they have gross extranodal extension greater than 1 millimeter, multiple nodes positive in the neck, that's greater than 5 nodes positive in the neck. These patients typically are treated with adjuvant chemoradiotherapy, but there are trials, again, such as Pathos, as well as a recently completed trial from Mayo Clinic, MC 1273, which I'll talk about next, where they are trying to tailor the chemotherapy or tailor the dose of the radiation. Ask the question, is chemo completely necessary, or can we give RT in a slightly different way, maybe accelerated dosing or less doses, etc., and still maintain outcomes for these patients? And so this is really exciting, and these trials I think are going to change, hopefully, how we practice in the very near future. So here's the data from Daniel Ma, who was the first author of this paper from the Mayo Clinic. MC1278 was the name of the trial, this was a phase 2 evaluation of aggressive dose de-escalation, as you can see in the adjuvant setting. So this was a single-arm trial that had 2 cohorts. There were 80 patients, all with stage 3, stage 4 by AJCC 7th edition, Hpv Associated Oropharyngeal Cancer. All patients had surgery. The patients were then broken into 2 cohorts. Cohort A was defined as patients that had T3 or N2 disease, maybe had PNI but did not have extracapsular extension. And these patients were treated to 30 gray of radiation, so significant de-escalation, 30 gray, but given twice a day in an accelerated fashion, so in a shorter time frame, they were given 1.5 gray BID with paclitaxel. And those patients who had extracapsular extension, gross extracapsular extension or ECE, were treated to 36 gray. Once again, given in 1.8 gray BID, delivered also with paclitaxel. And the data were really quite striking. You can see here the local regional control rate was 95%, and the 2-year disease-free survival rate was 89%. And once again, really, really good survival. And again, we're sort of hovering at that 90% range even for this study. And this paper has been published. I'm showing you here the title slide from the abstract that was presented at ASTRO a few years ago, but this paper is now published. And I believe that they have gone on to extend this in a new study called the MC 1675 trial, which is completed, and we're all eagerly awaiting for those data to mature and be reported out in the near future. And I encourage those of you that are interested to tune into the American Head and Neck Society webinar in the summer to hear Dr. Ma present these data. So, given this interesting phase 2 trial of de-escalating or changing the dosage pattern, there's some evidence that suggests that this could be done in a safe fashion. We also wanted to ask a similar question with a different, slightly altered schema here. This is Ecog 3311, a trial that was led by Dr. Bob Ferris from UPMC. And this trial actually was a multi-center trial that was the first of its kind, to my knowledge, to use a surgical quality metric to ensure that all surgeons that participated on this trial were held to sort of a same standard in terms of the type of surgery that was done. And in this particular trial, which first of all I think is quite unique, but in this particular trial, we used patients that had Hpv positive disease, stage T1 to T2, N1 to N2B disease, so N0 patients were excluded from this trial. Patients that had low risk disease, once again T1, T2, N0 to N1, that is if maybe you thought there was a node that was positive on the PET scan or on the CT scan but turned out to be pathologically negative, that would downstage the patient to an N0. These patients were treated with observation. Any patients with high risk disease, that is positive margins, gross extracapsular extension, or multiple lymph nodes positive, were treated with definitive therapy with cisplatin with radiation to 66 gray. And patients who were intermediate risk, that is, had negative or close margins, but had microscopic external extension or more than, or up to 4 nodes positive, I should say, so 2 to 4 nodes positive, were then randomized to be treated with either IMRT to 50 gray or IMRT radiation to 60 gray. So here we have avoided giving chemotherapy for these patients in this intermediate group. These data were presented at ASCO last year. In terms of the oncologic outcomes. And what we find, once again, not surprisingly, is that these patients, who all the patients had about a 90 to 95% survival rate. Interestingly, the survival was slightly worse in Arm D, that is patients that needed triple modality therapy. However, in the patients that had that were randomized to 60 versus 50 gray, so that's Arm B is 50 gray, Arm C is 60 gray, you can see that both of these groups enjoyed an excellent 2-year progression-free survival of 95%. And Arm A was a very small number. Only 37 patients fell into this group who had no need for adjuvant therapy. Once again, these patients had an excellent survival at 94%. The toxicity was reasonable in these groups. One patient was a surgical. There were 2 deaths in this group, in this entire cadre of people, and you can see here over 300 patients in the study. 2 treatment-related deaths, 1 surgical, and 1 in the Arm D in a patient who had surgery followed by chemoradiation in an adjuvant setting. So the endpoint of this study is that given these data, there is equipoise to potentially have a further study to look at 50 gray in the management of these patients. And while this is a phase 2 study, it should be noted that some radiation oncologists feel comfortable de-escalating patients to 50 gray on the basis of these data. However, the point that's really interesting that I think we should consider is that the patients in Arm D, those that have a 90.5% survival, seem to do poorly, although they were treated with chemotherapy and radiation therapy. And so this begs the question, what is the impact of extranodal extension on patients with Hpv positive disease? And here's some really nice data published by Jessie Maxwell in the journal Cancer, where she looked at patients with Hpv positive versus Hpv negative disease and stratified them further by the presence of extranodal extension. And in fact, she found that in the context of Hpv positive disease, it really didn't matter whether you had extranodal extension or not. So this then raises the question, but why did the people in Arm D have that sort of worse survival? Is it just because of extranodal extension, or is it some biological parameter that sort of defines that cohort of patients? And so that's really an interesting question to ask. At UPMC, we have designed now another trial to further de-escalate the patients in that high-risk group. So these are patients who meet the eligibility criteria for Ecog 3311, would have robotic surgery or transoral surgery by any approach. And those that are in Arm D, that is the group that got chemotherapy with the radiation to 66 gray, these patients are now getting radiation to only 50 gray. And instead of getting chemotherapy, they're being treated with nivolumab, which is an immuno-oncologic agent, in an attempt to maintain their survival while reducing their potential treatment-related toxicities. So this is a very interesting area, and I hope I've sort of shown you some of the existing data, which shows why people are in fact interested in using surgery to de-escalate patients with Hpv positive, de-escalate treatment for patients with Hpv positive disease. But I don't want to give the audience the impression that the only work being done is in the surgical space. There are also several trials that seek to de-escalate patients with definitive chemoradiotherapy. And so here, what I wanted to go over was some of these trials and what we have learned from these. So one really important study that everybody should be aware of is the Rtog 1016, which is a randomized phase 2 trial of, randomized phase 3 trial, of patients being treated either with cisplatin with IMRT for Hpv positive oropharyngeal cancer, or being randomized to getting treatment with IMRT with cetuximab. And the concept here was that cetuximab, because it's an anti-EGFR based antibody therapy, should have less toxicity than cisplatin, and that this decreased toxicity should therefore manifest itself in the patient's quality of life. And so that was really the design of this study. It was meant to sort of test head-to-head cisplatin versus cetuximab in these patients. Interestingly, not only were these patients not having a better quality of life or less toxicity, it actually turned out that their survival was worse if they were treated with cetuximab. So this was a shocking bit of data, and this led people to feel that cetuximab, well, first of all, the trial was stopped early because of this finding, and it sort of awoke us to the fact that cetuximab should not be used to treat patients with HPV positive oropharyngeal cancer. Now, the underlying biology here is really fascinating, and I don't know why this phenomenon happens. It probably has something to do with the molecular signaling of HPV positive cancers, but at this juncture, we can say that these patients should not be treated with cetuximab if they're eligible for cisplatin. Another trial that seeks to de-escalate treatment for these patients with oropharyngeal cancer was led by Suyam. This is HN002, which is completed and recently reported out. And so here, patients who had less than 10-pack-year smoking history were randomized to receive radiation alone versus radiation plus cisplatin over 6 cycles. And so this is 60-degree radiation versus 60-degree radiation plus cisplatin. And this, again, was effectively a negative trial in the sense that of the patients that were randomized and of 292 evaluable patients, the 2-year progression-free survival was somewhat better in the group that got cisplatin versus the group that got IMRT alone. And the 87% for the group that got IMRT alone is clearly less than the historical control of 90+%, right? From the Rtog 0129 paper, the very first New England Journal paper I showed you, this 80.5% clearly is less than that 93% survival that you would expect. So this led a lot of investigators in the field to be worried that giving patients de-escalated therapy was not a good idea. And therefore, there's been great consternation to de-escalate definitive chemoradiotherapy for these patients. But I think we can still acknowledge that even those patients that were treated with surgery up front and who needed adjuvant chemoradiotherapy had poor outcome when compared to those patients that did not need that. That 90% survival versus 95% survival still came out of the Ecog 3311 data. So this led my lab to ask the question, what is it about those patients that fail treatment or what is it that drives these tumors to not respond to therapy? What are the differences in the primary patients who are cured versus those that fail? And is there some genomic characterization that we could ascribe to these patients to try to define this better? And in fact, we took on the study, and this is work that was done in collaboration with Eddie Mendez, a colleague of mine at the University of Washington, who unfortunately 2 years ago succumbed himself to cancer. And we co-mentored Alex Harbison, who's shown here in the picture, who is now a fellow at Johns Hopkins in head and neck oncology. And Alex, Eddie, and I compiled a cohort of patients who had HPV-related oropharyngeal cancer, all staged as stage 1 or stage 2, who then underwent treatment, and then we identified the recurrent tissues from those same patients when they had salvage surgery. And we subjected these tumors to next-gen sequencing, and we identified a whole transcriptome analysis of these tumors. And so we compared the primary tumor to those tumors that recurred. And when we compared these two cohorts, what we found by doing some fancy computational analysis, which is beyond the scope of the current talk, is that there were several hallmarks, most of which were driven by metabolism that came out as pathways that are dysregulated in these recurrences. This includes, as remember I told you, P53 is a very important pathway, P53 dependent DNA damage response, so this was a very important one. This is not surprising. It sort of tells you that these tumors that are more aggressive tend to have ways to escape their DNA damage. There are also hallmarks of something called NRF2, and NRF2 is the nuclear respiratory factor, which drives metabolism in a significant percentage of tumors. And in fact, NRF2 genes are mutated or overexpressed in a significant number of tumors, including lung cancer, ovarian cancer, and others. And NRF2 gene signature changes have been associated with treatment resistance in those cases as well, in those pathologies as well. And lo and behold, when we looked at the TCGA, or the Cancer Genome Atlas, then what we found was the expression of NRF2, or the NRF2 activation signature, in fact portended very significantly the survival for these patients with Hpv positive oropharyngeal cancer. And so therefore, it's very provocative, and while these data are very new, they're just sort of hot off the press in my lab, and I wanted to share them with you. I don't think that we should be making any treatment decisions on the basis of this. But my hope is that in the next wave, we will no longer be simply staging people based on TNM, but maybe we'll be incorporating genomic profiles or genomic signatures to further delineate the phenotype of these patients and determine which patients do well with surgery or could do well with surgery, or maybe which ones should do better with chemo or radiation therapy, or maybe those that should be treated with in a completely different paradigm altogether. So it's a very exciting time in this space, and there's going to be a lot of data coming forward as we think about ways to de-escalate patients' care who have HPV positive head and neck cancer. So in summary, this is a rapidly evolving field. I think there's great trepidation and at the same time excitement in discussing de-escalation and rational de-escalation for these patients. I think the current practice is to stage patients by the 8th edition of AJCC, but I really want to emphasize this, especially to the trainees in the audience, that although we stage people based on the 8th edition AJCC, and you may stage somebody as a T1, we still should be treating these people on the basis of the 7th edition of the AJCC. And so you stage by the 8th, but you treat by the 7th. So just because somebody's a T1N1, but if they have multiple nodes in the neck, or they have N2C disease, bilateral nodes, etc., those people cannot be de-escalated without good data. I think more data is forthcoming, and we are waiting for the full publication of the Ecog 3311. I know that the paper is in review currently because I have an author on the paper, and we hope that it'll be published soon and we can all read that. But while that data is going to be published, the de-escalation of treatment for these patients, I think, will become standard of care in the not too distant future, mostly based on 3311 and some other data, but this is solely my opinion at this juncture. However, at this point in time, I think that for patients with early stage or low volume disease, that is patient stage T1, T2, N0 to N1, these patients can have definitive radiotherapy or be treated with transoral surgery followed by observation if in fact the pathology confirms that these patients truly have only one node in the neck or no extracapsular extension. And for those patients who maybe don't want surgery or not good candidates for surgery, then these patients can be treated with RT alone or RT plus systemic therapy in the context of multidisciplinary care and clinical trial enrollment. For patients with advanced stage disease, that is any stage, T stage or N stage, and who have bulky disease, then these patients would benefit from concurrent systemic therapy, and probably these patients would be best served with non-operative management, in my opinion, although there are some who would make an argument for transoral surgery if the patients are unable to tolerate systemic immunotherapy or systemic chemotherapeutic agents. So with that, I'd like to end, and I thank you for your attention, and I'm happy to answer any questions.